everyone. I welcome you all on the second day of webinar on Oncology Up to Date 2022. With immense pleasure, I would like to invite Dr. Akash Tiwari, who is consultant medical oncologist, Shalby Hospital, Indore, for his welcome and introductory note. Over to you, sir.
Hi, good evening, everyone. Thanks for joining these sessions. So today our sessions would be focused on prostate cancer, RCC, and hematological malignancies. I hope we have a wonderful academic feast. The first speaker today would be a very dear friend of mine, Dr. Mehlem Kausar. Dr. Mehlem Kausar currently is assistant professor in cancer hospital at MY Hospital. Mehlem, the stage is yours.
Thank you. Okay, thank you, sir. I'll just share my screen once, 2 seconds. Is it visible?
Yes, sir. Yes, sir.
Okay, so good evening, everyone. First of all, I would like to thank the organizing committee as well as Akash for giving me this opportunity. So my topic for discussion and speaking is basically the role of PARP inhibitors in prostate cancer. So this is a new drug, not very new to us basically, but a drug new which has been approved in prostate cancer, especially in the castrate-resistant metastatic prostate cancer. So let us go through the details of that. So since 2019, FDA has approved two drugs of two PARP inhibitors in prostate cancer, that is olaparib and rucaparib. So what we will see is when to use them, in which patients, and what to expect out of them. So how are PARP inhibitors used? So they are currently used in treatment of metastatic castrate-resistant prostate cancer, mostly used in those which have a biomarkers like either DNA repair mutations in the DNA repair genes, that is either BRCA1, BRCA2. They are maybe most sensitive. Rest other genes like the HRR genes mutation, which is done on NGS. Other drug which is rucaparib, which is mostly used for BRCA1 and BRCA2 only, as per the evidence which is present. So when to use these drugs? So basically they are not yet approved for the first line therapy, and it is mostly after the androgen receptor targeted therapy, that is either the abiraterone or enzalutamide, or after chemotherapy, or can be mostly used as a monotherapy right now. So let us discuss about olaparib in prostate cancer. So it was the first drug which was approved in May 2020 for metastatic CRPC, especially in HRR gene mutations, either germline or somatic. And this approval was based on the phase 3 data of the PROfound data, which showed an improved PFS. The median PFS was maximum for the mutation of BRCA1, BRCA2, and there was no benefit in the ATM mutations. So let us go through some details of this study. So this was the trial design of the phase 3 PROfound study, where olaparib was randomized against physician choice in progressing metastatic castration-resistant prostate cancer. So all patients have received prior either androgen receptor therapy, either in the form of abiraterone or enzalutamide. So there were two cohorts, one cohort which were BRCA2 and ATM mutated, and the other cohort which were the other alteration as mentioned downside, which were the BRIP, BARD1, CDK12, CHEK1, and as mentioned downside. So the main primary endpoint was the radiographic PFS in the cohort A, as well with the RECIST response criteria. So what we can see through this curve is that there was a significant improvement in the median progression-free survival, as we can see in the first graph, that is with the hazard ratio of 0.22, which is a great difference. So olaparib doing much better in patients with BRCA1 and BRCA2 mutation. In the second, we can see that, as I mentioned earlier, that in patients with ATM mutation, there was no great benefit. And similarly, there was some benefit, but not as great as benefit as in the BRCA1, BRCA2 mutation with those patients with CDK12 mutation. As with other drugs, the PFS was converted into an OS difference also. And similarly, in the BRCA1, BRCA2 mutation, there was an absolute difference of 4 months with a hazard ratio of 0.61, which is quite good. As similarly in ATM and CDK, there was not such a great difference. However, in CDK, the hazard ratio was again 0.65. And 80% of the patients in the control arm were crossed over to receive the olaparib on progression. So similarly, as mentioned earlier, not all mutations do benefit, as we saw in the Kaplan-Meier curves also. BRCA2 patients having the maximum radiographic response, And similarly, those patients with RAD51 and RAD54 again having a good response, and patient with CDK12, ATM, and check2 mutation having a minimal response. The similar is shown on the forest plot also. Again, as we all know, the side effects associated with the PARP inhibitors, anemia, being the most common, other being fatigue, asthenia, decreased appetite, vomiting, and nausea. But all these are well controlled. So the second drug which has been approved by FDA in metastatic castrate-resistant prostate cancer (CRPC) is rucaparib, which was based on a phase 2 response-based study, that was the Triton-2 study, with a confirmed overall response rate of 44%. Sorry, the phase 3 study comparing rucaparib versus physician choice of therapy is still ongoing and recruiting, with a planned number of recruitment of 400. So this study was basically similar. Rucaparib 600 milligram BD in a 28-day cycle until radiographic progression in patient with metastatic CRPC, those with either deleterious somatic or germline mutations in alteration in the HRR genes. Patient has received the androgen receptor based therapy as well as a prior line of taxane based therapy. One thing to note here is the profound study, there was no patient which were been taken who has received a prior taxane based therapy. In these, even those patients who have received a one prior line of taxane based therapy were also being included. So the primary endpoint, as I told earlier, was basically the overall response rate. So these are the baseline characteristics of the patient. The maximum patient being in the BRCA1, BRCA2 mutation arm, the other alteration being ATM, CDK12, and other mutations. As mentioned, downside, that is the BRAF, CHEK2, NBN, PALB2, etc. So this we can see through the graph that most patients with BRCA1, BRCA2 mutation had responses, and many patients had very good responses also. Either it was either somatic or germline mutations. Similarly, again, the same thing, but with other mutations, we can see that maximum patient who had BRCA mutation did fare better as compared to the other mutation. Our patient with BRAF mutation also had some responses. So Triton-2 patients responses, PSA response based on the mutation type. So as we seen in the profound study, the same thing we can denote here also. Those patients with ATM mutation didn't have great responses. However, those patients with BRCA mutation had the maximum responses, as well as other mutations did had some responses. So again, the responses were durable, with majority lasting for more than 24 weeks. Again, the same thing with other, as with other PARP inhibitors, fatigue, anemia, nausea are the most common side effects, with anemia being the most common, having with the more grade 3 toxicity in 15% of the patients. So this is the phase 3 study which is ongoing, and patients are being recruited. Patients with metastatic castrate-resistant prostate cancer with somatic or germline BRCA1 or BRCA2 mutation, those who have received prior AR-based or taxane-based therapy to either rucaparib or physician choice. So this is the taloparo study, which was another phase 2 study, which was talazoparib 1 milligram per day and 0.75 in the moderate renal impairment in patient with the biallelic DDR alteration in the ATM, ATR, BRCA1, BRCA2, and other mutation, with the primary endpoint being overall response rate. Again, the overall response rate, which we can see through the table, is maximal in 50% of the patient which have been the BRCA1 and BRCA2. Some patient in ATM. Just 2 seconds, sorry. 2 seconds. I'm really sorry. So basically, the patients with BRCA1, BRCA2 mutation fared maximally better even with the talapro study. Similarly, again, the same toxicity profile as I mentioned earlier. Another study, which is the Galahad study, which was containing niraparib in metastatic CRPC with biallelic DNA repair defects. Again, niraparib 300 milligram in 28-day cycle. So the primary endpoint was overall response rate. Again, the patient with BRCA1, BRCA2 mutation as compared to the non-BRCA mutation or non-BRCA patient fared better, with the overall response rate in 41%, with more than 50% decrement is seen in 50% of the patient. So what we observe or what we get through all this thing is that PARP inhibitors are active drugs in metastatic prostate cancer, especially CRPC, with response rate ranging from 40 to 60. Many patients do have a favorable response and a long-term response. Not all mutations do good. Some mutations do good, some mutations don't do good, especially the BRCA benefits the most, with ATM having no significant benefit. And there is acceptable safety profile, as with we know with PARP inhibitors, the hematological toxicity being the most common side effect associated. So as we have seen this graph earlier. So what I want to mention with this graph is basically that not all mutation do same. As we can see on the left hand side, that some patient even with BRCA mutation didn't respond well, but most of the patient with BRCA mutation did respond well with the PARP inhibitor. So not all patient with mutation will respond to PARP inhibitors also. So this is just an overprescription of all the drugs, that is PARP inhibitors, olaparib and rucaparib being approved in prostate cancer, and others being in the way for the I'm really sorry. I'm really sorry. So these are the drugs which are in development for even prostate cancer also. So does PARP inhibition help a patient without DDR mutations? So this is one of the study where it was been shown that abiraterone acetate may improve the outcomes, especially the PFS and PSA in patient with DNA repair deficiency also. So this NCI 9012 study So this was one of the studies where patient tumor with DNA repair deficient had better, more durable responses than those with wild type DNA repair. So there is a concept of synergy between the PARP as well as the androgen receptor signaling. So androgen receptor signaling blocks the nuclear receptor. Thus there is a decreased DNA repair block, double distant DNA increase. Thus there is synergy with PARP inhibitors. So can we use this concept and synergy in our clinical practice? So there has been ongoing data of combination of anti-androgen therapy and PARP inhibitor in combination. So there was this study which was an olaparib plus abiraterone in metastatic CRPC, a randomized double-blind placebo-controlled phase 2 trial in patient with prior treatment with docetaxel or less 2 lines of prior line of chemotherapy. Olaparib plus abiraterone was compared with placebo and abiraterone until progressive disease, with primary endpoint being the radiological PFS. So what we can see in this Kaplan-Meier is basically that patient even with HRR wild type fare better with a hazard ratio of 0.52 with a median PFS of 9.7 in placebo plus abiraterone as compared to 15 months in the olaparib and the abiraterone arm. And similarly, in the HRR partially characterized patients, the hazard ratio was 0.67. So even those with the DDR wild type or HRR wild type patient fared better when we combined olaparib plus abiraterone. However, this is still not been FDA approved. The major concern being the side effect profile associated with the combination of the therapy, which is mostly the hematological toxicities, as we can see into this table. So this is another study which is ongoing and recruiting, which is basically in the previously untreated metastatic CRPC, where combination of rucaparib plus enzalutamide is compared being with enzalutamide plus ADT. The recruitment is ongoing and the results are awaited, which will give us much more insight into whether we can use the combination or not. So what finally I would like to conclude is 15 to 25% of metastatic CRPC harbor alteration in DNA repair genes. PARP inhibitors do work in prostate cancer, but depends upon the patient selection. BRCA2 and BRCA1 is the most sensitive. ATM may be sensitive. Selection of biallelic gene is still a matter of debate. So a lot of work ahead, which that is basically selecting a specific biomarker or a correct biomarker for using these agents correctly. And another important thing is the combination, whether the combination fares better as compared to a monotherapy. Thank you.
Thank you, sir. Thank you for the wonderful presentation. And next we move on to today's panel discussion, which is on management of MCRPC. And for this, I would like to invite our moderator of today, Dr. T.P. Sahu, who is consultant medical oncologist, Silverline Hospital, Bhopal. Over to you, sir, to take forward the panel discussion.
Yeah, hi. Let me share my screen first. Is my full screen visible or is it not visible?
Yeah, screen is visible. Just make it a slideshow mode, sir.
Okay. I'll just do that. 1 minute. Stop share. Again, I'm going to share this. Now it's there?
Yeah. Yes, sir.
Okay. So thank you, organizers. Thank you, both of you. And we have a panel which is all the panelists are there. May I can someone guide me on that? Praveen, Sunit, Ashish. Hi,
sir.
Praveen.
There, Ashish sir. Hello, sir. Sir, Ashish sir and Taha sir will join in a couple of minutes. And
sure.
Gupta,
so I have Gaurav.
Sir,
Gaurav is there?
Sir, he has joined, but I think his network connection is a little low, so he's log off. And Sunit Lokwani sir will not able to join.
I am around, sir. Hi, sir. Akash this side. I am around.
Hi, Akash. So
Hi,
we have you in the panel. We have Praveen in the panel. And just give me 1 second. Someone can correct to Gaurav because I would like to have a radiation oncology. If you can join, that's well and good. But till he comes in, let's start off. Okay.
Yes, sir. He will join in a couple of minutes.
Yeah, that's fine, Aram. Just connect with him and request him to come. So we have Praveen, we have Akash. That's it, and Gaurav will join. Okay, let's take it up. Okay. So I'll just go to very clear things. Dr. Praveen, now tell me, for you as a metastatic, when you see a metastatic hormone positive, hormone sensitive prostate cancer, what do you feel like? Do you risk stratify the patients, or would you just look at the disease load and treat every patient the same way? Just give a starter before we move on to the things. Yeah, Praveen.
So basically, after the diagnosis, sir, we do the staging workup. And
yeah, you have staged it. You have found it to be a metastatic disease. And now the patient is upfront de novo metastasis, see a prostate with advanced disease, has bony mets. So how do you proceed further?
So first, sir, based upon the burden of the metastasis, the skeletal metastasis, the low risk versus high risk, and visceral versus the non-visceral metastasis, and the PSA level. Although there is no cutoff, but the PSA level.
So would you define, how would you define which of your patients are high risk?
So more than 4 skeletal metastasis, sir. Other than the appendicular skeleton. So and then the visceral metastasis, they will be obviously high risk only.
Okay. So basically that's what we are dealing with in a chartered and the latitude. These are two most talked about trials. And these nearly talk about the same thing. One is they have little different inclusion criteria where they define one as high risk or high burden. That I will put it in the better way. But what I mean to say is they do have the one, anyone who has a bristle metastasis is definitely a patient who is of high risk criteria. Like in the latitude, you have someone with a Gleason, they have taken 2 out of the 3. So a Gleason score they have taken into consideration, which is not a consideration in the charter. And then the presence of more than 3 bony lesions on bone scan, they have not defined the site. In contrast, the charter is very clear that is at least 4 or more, and one of them at least should be beyond the pelvis or the vertebral column. So these are some minor differences, but all said and done, it looks like any visceral disease. Both the trials do take them as high risk, and even more than 3 bone mets, but preferably beyond the pelvis and the vertebral column. If it is there, you would consider it to be a high risk. PSA is not considered as such, but all of us know the higher the PSA, more is the bulk of the disease. But there are many patients who have high-risk patients who do not have a very high PSA. Synchronous, metachronous, I'll leave it for some other day. I'll just move forward. This is something which I want to take it forward. And Akash, I want to bring you here. We have a 67 years old diabetic with hypertensive. The PSA is 122. The good performance status, it was a hard prostate on digital rectal examination. We have a PSMA PET scan. So let's stop here and ask you, if you have a patient who has come to you with this and has a bone scan which is showing multiple bony lytic lesions with a CT scan, do you feel the patient requires a PSMA PET? Question number one. And then we'll move forward.
No, sir. We routinely do not get PSMA PETs for our patients done.
Okay.
So not in cases which are clear-cut metastatic, which are clear-cut high risk, we do not do a PSMA PET in these patients.
Okay. So others in the panel who are there can put it in the chat, who are there, because it's a small group, I feel. And this is a very interesting.
Taha sir and Gaurav sir has joined, sir.
Gaurav has joined? Very good.
Yes, sir. Taha sir also.
Taha has joined also. Okay.
Hello, sir.
Taha, I was asking
Yes,
about PSMA PET. So do you feel in a patient who has walked down to you with a diagnosis of Gleason 10 prostate, has a bone scan and a CT scan with them and showing multiple bony lesions, maybe 8 lesions across, do you need a PSMA PET scan?
No, sir, not required. Not required.
Okay. So which patient do you feel is the eligible candidate for a PSMA PET scan?
Sir, I usually do it for localized disease at high risk, suspecting a metastasis.
Okay.
In those cases, I do PSMA.
Okay. Praveen, any second thoughts, or do you have something because you want to define the extent of the disease on upfront, even if it is there, I would like to do it.
The bone scan is showing the multiple lesion that fit into the high risk, so I will not do. But if the bone scan is showing 2 or 3 lesions, but the PSMA upstate the disease, then in case I will like to do the PSMA, because PSMA can pick up the more lesion than the patient. The criteria
so
will be different.
basically, if you are telling me that if you are yet to define the high risk criteria, if there is no visceral disease in whatever things they have done, you would probably prefer it because your treatment might change. Otherwise, you would not be going for it. And you would, if you have already a scan which is telling you that it's a high risk, you would not bother to do a PSMA. That's the take home message.
If the CT scan, chest, abdomen, bone scan has been done and it is showing the high risk, so I will not do. But if it is showing.
Fine, fair enough, fair enough. So I think this is something very important for all of us to remember, because with the advent of these costlier scans, we have been finding even patients who have multiple disease, even in lung mets, again going back to do a PSMA. And I don't know why they go on to do a PSMA. But what is required, and if you go to the guidelines and you have taken the ASCO, the PSMA PET scan is not helpful in the majority. And basically the helpfulness comes in the lower PSA range, where is the 2 to 4 degree or 2 to 4 value. There the PSMA normally picks up more metastatic disease than what it is. And Taha rightly told, if they are thinking of a radical treatment or a surgery or a radiotherapy radical intent, you want to define whether there's a oligometastatic disease somewhere, you would probably go for a PSMA. But if someone has a high risk criteria fulfilled, as Praveen is speaking, you would not spend the money on that. And what you really require is a bone scan, a CT scan, and a MR. That should suffice. And if you look at one of the guidelines that has come from the developing countries, the best practice, the PET PSMA could be there. Even in the best of centers you see in US and Europe, 50% do not do it. But they have told in limited resource, you need not do a PSMA PET scan in these subset of patients. You can limit it to those where you want to do a metastatic workup and where you are going to define your treatment. So this question to you, again, Akash, do you feel it is any different? LH agonist versus antagonist, surgical versus medical? Your thoughts on these 2 points?
So, sir, in terms of surgical versus medical, we know that both are equally efficacious. In our practice, we encourage our patients to get a surgical orchidectomy done, especially if, say, they come from a far-flung area or their compliance is not good, or old, frail people, whom we feel that they are likely to discontinue medical management soon.
So basically, you are pointing out that anyone who will feel very suspicious and do not have the deep pocket to continue the medical oncology for life, you would prefer a surgical, and you treat both of them equal on conditions of the oncological outcomes. Is that a take-home message? Perfect.
Yes, sir.
Taha,
and so in terms of agonist versus antagonist,
no, let Taha take it.
Sure.
Sir, I agree with Dr. Akash. Same thing, sir. If any doubt on
agonist versus antagonist. Where do you feel you need an antagonist?
Sir, only in case of where I'm suspecting a cord compression, where I need, I cannot afford to have a flare.
Okay.
Condition like a cord compression, basically. There I
otherwise, you would be comfortable with the LHRH agonist.
Agonist, yes, sir.
Perfect. So, Praveen, any different thoughts on antagonist versus agonist?
So there was a trial, sir. So because the patient who have high cardiovascular risk, so because there was some benefit with the antagonist, because they are diabetic, history of CID. So initially 6 to 8 months, the antagonists do better because they have a decreased CV mortality. Okay. So although there was phase 3 trial that was stopped earlier, but there is some evidence. So in that case, we may use antagonists. Otherwise, both are equal, sir.
Okay, there's a very pertinent point that Praveen has picked up, and I would put that question in a different concept, maybe, and I put it right now. I had a different slide for that. What Praveen is talking of is the cardiovascular event that do happen with LHRH agonist more than the antagonist, and that is where in a high-risk population with already a known cardiac, and the pocket is deep enough because the loading dose is quite costly for antagonist. Then that's where he would prefer an antagonist because efficacy wise, he feels both are same, and that's a fair point to it. Can I put a question to maybe Akash? Would it not be prudent for me to do a LH medical orchidectomy and do intermittent hormone ablation? Will it not take care of the cardiovascular risk which Praveen is speaking of?
So it's a fair deal, but I am not sure if only using an LHRH agonist also would add to a significant risk, sir. So in my practice, we are only using agonists when we are using.
To be fair to the panel, Praveen has put up a very pertinent point, and I will give it to him that there are cardiovascular toxicities which are documented lesser in antagonists, and that has to be given to them. The onset of action is quicker, which Taha put up on the spinal cord compression. You do not want the flaring up to happen. These are two specific indications. Probably the flaring up is one of the very clear indications. All of us agree. Cost is more higher. Efficacy is similar. But there is a point that if you have a LHRH agonist, the patient has not been on antagonist, and there are a lot of literature telling you that intermittent ablation of hormone do have equal efficacy than continuous ablation. And that could be a way to decrease the side effect of the LHRH agonist. So now, we have covered the first point, agonist versus antagonist versus orchidectomy. I'll skip there. Now let's come down to 2. Praveen, what is your level of testosterone if the patient is on medical orchidectomy?
The lower the better. Earlier it was, we used to say less than 50, but ideally it should be less than 20, sir. So okay. 20 testosterone.
Okay, ideally less than 20. You want to put the bar much more on the lower side, but 50 is okay with you. So are you telling me if you have a patient on a medical orchidectomy 35, you are not happy? You want to do something to that patient, or you would be okay if the patient is comfortable?
No, because that is because that much level is achieved with that particular drug we are using. So I will not change based on the level. So because that is the patient, the biology that is doing, but the lesser the better. So I will say. So I will not change the treatment based on whatever level we have achieved, because we have done orchidectomy and the level is maybe 35. We cannot do anything for that value, sir.
Any additional points on this? It's a very important thing. When sir, a patient on medical orchidectomy, you would like to look at the testosterone levels very carefully.
If on follow-up the PSA levels are declining well and symptomatically patient is fine, as long as testosterone levels less than 50, I won't bother, sir.
Okay. So both of you are right in one aspect that yes, 50 is the cutoff, and still the guidelines do mention it, but there are a lot of literature coming up that to put it 20 as the limit where you would be comfortable, and there are issues. People want to put the testosterone level to below 20, but till now even 50 is where the things are. Bisphosphonate rank the biological inhibitors. Akash, very quickly. Do you do bisphosphonates in a metastasis in a hormone sensitive patient? And if you do it, for what reason do you do it?
So, sir, we usually for the part of the disease per se, do not use bone modifying agents, either bisphosphonates or rank L inhibitors in our patients. I have yet to find a individual who's osteoporotic at this age, sir, there are 60s, 70s. But if an osteoporotic patient presents, probably then they may receive a bone modifying agent, a bisphosphonate or rank like inhibitors, depending upon the renal dysfunction, for the osteoporotic dose, sir, not per se because of the disease.
Stampede proved that there was no difference in survival. Point number one. You would probably have a lesser skeletal events. Point number two. Frequency, we are now moving towards once in 3 months. But yes, on the survival part, it is now more clear that these agents, bone modifying agents, do not contribute to the survival component. The skeletal component, the skeletal event as defined, yes, it is there. So now for this patient, this is the patient, Gaurav, I want you to be here now. So this is the patient, this is the PSMA PET scan. And Gaurav, what would you define this patient to be as? Gaurav, you're there? Someone told he has joined?
I am here.
Yeah, Gaurav, are you able to see the screen?
Yeah, sir, it's a patient is having multiple bony metastasis. Lesions of 5+5. So not a proper candidate for radical radiotherapy. I'll like to start with androgen deprivation therapy.
No, now that is started. Now you tell me, this is a low risk or high risk?
Sir, high risk.
Praveen?
High risk, sir. High risk.
Define the high risk if there is no visceral disease and you have all the metastasis in the appendicular skeleton and the pelvis. As per the criteria, where is the high risk?
I think, sir. So, but in the, I think I am not clear, but in the appendicitis, the lesion are more than maybe 5, so we leave it at like high risk.
No, this is the criteria. If you look at it, the charter is telling 4 or more lesions is okay, but one of which must be outside the column and the pelvis.
So one is seeing in the rib also, sir. So maybe the one is in out.
Okay, so you are able to see the one rib thing. Okay, let's presume for all debate's sake that you have this extensive metastasis. But Gaurav, I want you to take down to this criteria of chartered. And if you look at it, you do not have lesion anything beyond the appendicular skeleton or the vertebral column or the pelvis. Now there is no visceral disease. So now if this patient is defined as a low risk as per the chartered, what would you tell?
Sir, to continue with hormonal and re-evaluate the patient.
Okay, you do not advocate radiotherapy for the low burden, low risk to the prostate?
Upfront, not.
Okay. Akash, your thoughts? Would you consider radiotherapy to the prostate for the low risk patients? And does it matter?
So, sir, especially in oligometastatic setting, we do. And I think, sir, it improves at least. So most of these patients would somewhere in the course of the time progress locally also. I think it at least helps there.
Okay, so you would not do for all your low risk, you would individualize them. That's what the point.
Individualize them, but would prefer a local therapy.
Coming down to you again, where do you indicate or advocate RT to the prostate in a metastatic setting?
Sir, 4 or less bony metastasis. If there, then in that particular case, we must go for local RT.
Okay. So, yes. Okay, I'll come down to
Stampede
that.
4. Basically, Stampede 4 says that increase local regional control and improve survival also.
Okay. So I will come to that. Let me go to the medical oncologist for the systemic therapy part. What is your choice? Starting from Taha, then Praveen.
Sir, regarding the RT also, just one point, the low risk, I think Stampede trial had told there was slight, not local region control, there was slight benefits, sir, because of the Stampede. That's what I remember.
Okay, now I'll come down to this. I wanted this to be the last part of it, but because we are already in, I want to come to this part of it. This is Stampede and this is the chartered. These are two trials which have looked into this specific point, and both the trials, as per the criteria which is there, have proven that if it's a low risk, the local RT to the prostate does have a benefit. So if you look at the chartered, why I brought this, this is a point of debate. But when you look at the PSMA, it just looks too extensive. But if you look at the real criteria, there is no lesion, or at least one, if there is no bony lesion, at least one more beyond the vertebral column and pelvis, it does not fit actually into the high risk. Although if you look in the stampede, it does tell you more than 4, but you have to fulfill the criteria of 2 out of the 3 which I spoke. One was the Gleason score, one was the visceral metastasis, one was the more than 3 bony lesions. So that is why I brought this in, because if someone follows the chartered trial, and this is also a trial which has shown a benefit of a low risk with the survival for the low metastatic burden, and that is where it is. And this is a point where people feel, is it really that you need to have one beyond the pelvis if there's so extensive lesion? And our expert, Dr. Gaurav here, feels that he would consider the patient which he saw, he would consider for radiotherapy at a later point if there's a very good response. Am I right, Gaurav?
Yes, sir.
Okay, but look at the chartered, it tells a different story. Stampede tells a very different story. I think that is very clear on the radiotherapy part. And if you look at this, which Gaurav, I give it to Gaurav, this is where it is. Look at the number of bony metastasis. If it is less than 4, the curve is on this towards radiotherapy. If it is more than 4, it shifts away from the radiotherapy. The benefit goes away. This is probably what Gaurav was speaking, that if there is more than 4 lesions, he would not be comfortable. But because of the criteria which Stampede chartered followed, this was a controversial point. So now we'll come down to the systemic disease, and this is where I will tell you. So now Taha, tell me, what do you feel?
So because it's a low risk, low burden disease, I would
Gaurav told it is not a low risk for it.
I mean, as per the, I was going with the Stampede criteria. I mean, the chartered criteria.
Okay, so, you are going for the chartered. Someone wants to do Stampede, it is high risk then.
So I would start with ADT and either abiraterone or enzalutamide.
You either abiraterone or enzalutamide.
Depending on the side effect profile.
Okay, Dr. Praveen. Praveen is there?
Sorry, sir. Okay. I will take it a high risk only, sir. So based on Stampede trial, because number of lesion more than 4, sir.
Okay.
So ADT plus to discuss with the patient either chemotherapy or abiraterone or enzalutamide, sir.
So you will discuss both the options with ADT.
Yes, sir.
But you will give any one of them.
Yes, sir.
Okay, Akash, volunteers for piece 1?
Sir, ADT plus Enza.
ADT plus Enza. We had a publication just out today morning in NEGM, which does again advocate towards addition of a tablet with the systemic chemotherapy. What do you have to say about the piece 1 study and the recent publication in NEGM today? Any takers for the combo pack?
So the patient who is very fit, sir, so and very high risk disease. So PSA, because for this patient wanted to disease confined to the bony only, and we haven't used so far. So for that patient, obviously I will discuss, because the data is very strong, sir. The ADT plus the abiraterone or enzalutamide plus docetaxel. So.
Okay. But you have not changed practice as of yet. You would look into more further mature data to change practice. Is that
yes,
what I'm getting?
But I will be eager to use, sir, if they very fit and motivated patients, sir. All the 3 combo.
Okay, so you are eager to use it. Akash, agree, or you would skip the thing, waiting till you get more mature results?
No, I agree, sir. It is just that I am hesitant in using docetaxel in patients with a lot of comorbidities, elderly patients. Sir.
Okay.
So if it's a young, fitter patient, lesser comorbidity, probably yes, a combination in high risk.
Okay. Taha, any patient of yours would go for the Enza plus Dosi?
I don't think so, sir. I'll wait for the
you are still not convinced.
Results. Yes,
okay. Sir. So this is where I'm talking of, if you have patients with a problem, hot flushes and musculoskeletal, you can give the option of intermittent ADT. This is the trial which was published today in NEGM, the darolutamide combo with Dosi and with Dosi plus minus, and they found improvement, and that has now been there. But this is the ADT with docetaxel, and that is what I wanted to show. The D niveau, if you look at it, the all high and low, the numbers could be a little different, but it does play a major role. And if the fitness is there, high risk do much benefit with the combination of all the agents together. Means standard of care, which is Dosi plus the ADT, and here they added abiraterone. So this is something which I wanted to put it, but there are controversies to it. There are a lot of trials which are looking into it, and they have found like the Enzamet and the Arcase, they found that if there is a docetaxel, you add the enzalutamide, they do not benefit much. So that is also a thing that we need to consider. But the trial with the abiraterone was positive, but the trial with enzalutamide has been negative. So now with this controversy, Akash, is it that if you want to add an agent at this point and a young fit patient, it has to be abiraterone and not enzalutamide?
Preferably, yes, sir.
Okay. So this is something which I think is the future. In the high risk fit patient, all of us medical oncologists will be discussing this to the patient, although mature survival data is still lacking. I'll just skip off to tell you that abiraterone, the benefit is in low and high volume equally. Low dose abiraterone. Anyone does it? Praveen, you have done 250 mg OD?
I have, it's a very poor patient. I have given the option to the patient.
Why don't you give it to the rich patient also?
The evidence,
no, because science is there.
Evidence-based medicine, because that is the nobody can question, sir. But if this patient says, or I can afford, so
no. I am talking that there is evidence, equal evidence of the bioequivalence with the meal alteration of 250 abiraterone with the higher dose of abiraterone. So evidence makes you that you can even offer it to the best of the pocket patient with deep, very deep pocket.
So because with the food, sir, so how much food, how much fat, that is we cannot predict, sir. Because the empty stomach we know, and now we have the generic available less than 10,000. It costs 6,000 to 7,000 hardly to the patient. So if the patient can say, so then because most of the patients they can afford, sir.
Do you discuss it with the affordable patient? Let me put it very differently.
No, sir.
No, you don't discuss this. Very fair, honest answer. I like it. Taha, your thoughts on this?
No, I've never used.
You have never thought about it when you do abiraterone?
No, sir.
No, Akash.
So the benefit of the low dose abiraterone was predominantly in terms of cost that we are looking at, with the cost of abiraterone coming down significantly.
No, I'm looking at a very different aspect. If the bioequivalence is same, the efficacy is same. If I tell my patient 6,000 versus 1,000, even the Ambanis will tell me ko 1,000 rupees de do yaar, 6,000 nahi do. Who will want to spend more money?
I haven't ever discussed with patients who I think can afford
we as the
full
oncology
dose of
community are
abiraterone.
not convinced, and we probably have not looked into this part. I will request
use,
all of you
so sir,
to go into, yeah, please.
So sir, I've used low dose abiraterone. In fact,
but
there are 4-5 of my patients, but only for patients who are financially challenged, so not otherwise.
I would request all of us to go through, and if time permits, some other day we should discuss this trial, and this trial is really something which can be a path changer in this thing, and that is published in a very reputed journal. I think GSO published this. Docetaxel benefit is in high volume, it is less costly. I'm skipping this. Low burden relapse, you already told. Just this one part, if their PSA is lesser, you get more of the uptakes with PSMA. Dr. Gaurav, when you look into and the patient is not fit for surgery and patient are referred to you, if the PSA, let's say they come with a bone scan, they come with a MRI and the CT scan, and the PSA is, let's say, 3. Would you be comfortable doing a PSMA because there is evidence that you might lose 20-30% patient into the metastatic group and you might not be doing a radical intended radiotherapy? What's your take on that?
Sir, if PSA is low, bone scan is negative, there's no visceral metastasis, then I'll not like to go for PSMA.
Taha, we spoke something very differently. What is your thought?
Sir, sorry, I missed your question. I'm really sorry, sir.
I told if the patient is the elderly patient and the PSA is around 3 or 3.5, and the MRI, the CT scan and the bone scan shows no disease, before you plan your radical RT with a hormone, would you do a PSMA if given a choice?
Yes, sir. Exactly the criteria.
Okay, so this is where you felt the criteria was.
Sir.
I think the evidence points towards that, and that is where the role of oligometastatic disease does come in. So now, Dr. Gaurav, if there is oligometastatic disease, what is your approach? Prostate directed? You wanted to say something before the PSMA. Please tell that first.
No, I would like to go for prostate-directed therapy with systemic therapy.
Okay. So you would go for a prostate therapy in oligometastatic disease?
Yeah.
Okay. And with the systemic therapy?
With systemic
would you do radiotherapy to the metastatic directed therapy also?
No.
At this point, no.
At this point, no.
But is the data very encouraging for you and your fingers are just going to that next 2 years, the data matures, you would be doing that?
Sir, maybe. For there's data which is saying that to oligometastatic side, if you go for SBRT to that particular subsite and radical RT to prostate, then it's better.
Okay.
But it's not mature enough as of now just to practice it.
Okay. Akash and Praveen, would you send it to your radiation oncologist if there are 3 or 2 bony metastasis and the radiation oncologist is very, very encouraged to do even a metastatic directed therapy in addition to the prostate direct therapy for radiotherapy, although he will allow you to give the systemic therapy?
I do, sir.
You do. You are convinced.
Yes, sir. We will send our patients for
you send your
local
patient.
RT.
And your radiation oncologist also radiate the metastatic site.
So, sir, they as of now they do local RT.
Yeah.
If at that point there's a painful site or the disease is still active or more, they'll do local RT. Otherwise not, sir. They do local RT only.
The data, what it is what Gaurav told. At this point, even there is trials going on for surgery, but those trials are very far and few, not mature enough. The data for systemic therapy is already there. All of us know that. No one is challenging that. Radiotherapy to the prostate, although we have seen in the Stampede in previous trials that the metastatic disease also they have a benefit in the low risk, and this patient in oligometastatic will be defined as a low risk anyway. So that benefit is there. So no doubts about it. For the metastasis directed therapy, there are beautiful articles that's coming up. If someone really goes through the articles, you do feel that we are moving towards the time where the data, if matures in next 1 to 2 years, this will be a norm to treat oligometastatic, provided the data looks as good at the end of 2 years as it looks now. So Gaurav, that should be a take-home message for oligometastatic disease at this point?
Yes, sir. And there a new thing is also creeping in, which says even we can avoid irradiation to enlarge lymph nodes if they're in pelvis.
Okay. Yeah. There was a trial which is there, and I didn't want to discuss this in the essence of time. Last question, and then I stop. Praveen, do you do HRD or do you do HRR testing for all your patients of prostate cancer?
If the patient can afford the PARP inhibitor, then yes, sir. So I discussed with the patient, if the report come positive, if they can afford the drug, otherwise no, sir. So
okay. Do you look into the data which the first speaker spoke of ATM? If you look at the subset analysis of PROFOUND, you do find the ATM subgroup do not, although they were categorized in the group 1, along with the BRCA. And if you look at the subset, although we should not be looking much in the subset, it did not benefit. So if a patient comes as ATM1 positive mutation, would you go for a PARP inhibitor?
So that was a subgroup analysis, sir. But they will benefit less. So if I have exhausted all the options, I will offer the patient PARP inhibitor. I will say, but I will counsel the patient that the benefit will be less compared to the other person. I will offer, sir.
Akash, RAD 513, if that is positive versus the ATM, which are you very much encouraged with?
RAD more than ATMs.
Okay, so there is some data which is creeping in, and we need to look at the maturity. The BRCA1, BRCA2 story is not yet over yet. If you see, there is a differential response, but I agree and take Praveen's point that this is a subgroup not matured enough. The data is not powered to be looking at this, but all of us, as medical oncologists, want to look at those subsets. And when we look at the subset, if you look at group 1, which had BRCA1 and 2 and ATM, they did show a benefit. The group 2, which had the other mutations, was different. But when you looked at individual subsets, you do find that the ATM really disappointed us. In contrast, the RAD actually looked at very beautiful responses, and the benefit was much, much larger. Even the magnitude, I feel, if my memory holds right, was more than the BRCA benefit. So there is a molecular selection that's also going to come in. So with that, I stop here. Thank all the panelists.
So I have a question, sir. So that the triple combo that we are using, so ADT plus docetaxel plus abiraterone, what if the patient is not so fit? So you use the chemotherapy 6 cycle and then continue abiraterone. So that is middle path. So what is the how this the process?
So what Praveen is asking of is a sequential approach. So he tells me that because the patient is not fit to go for the combo approach, he wants to do the docetaxel plus ADT and then give the consolidation with the abiraterone. Right, Praveen? That's what you told.
Correct, sir. Because ideally, because patient will continue on the abiraterone.
Agreed. So do you do it, Taha, or you want to use the drug on progression?
Sir, sequential, not together.
So that is, you give 6 cycle dosi, and there is no progression, and you just switch over to the abiraterone?
No, I wait, sir. Just
you wait for
ADT
progression.
Continue. Yeah, already castration already done, sir. So
ADT is done. ADT is already there, plus dosi. Praveen wants, because the patient was not fit, so he wants to not add the combo high-risk patient. He wants to give sequential. That's what he meant.
Yes.
Okay, Akash, your last point. Do you want to give sequential or combo?
Sir, combo. If an option is there, combo.
And if you cannot give, would you wait for progression to happen?
Sir, I usually put them on the next line of therapy.
So you do not wait for progression?
I don't, sir. I am not sure.
Is there any data for that aspect?
No, sir. But I think, sir, most of the time, if the patient receives the second line therapy earlier, they have greater PFSs, and we have seen it in most malignancies, like the concept of maintenance in CA lung.
So before I end, I will volunteer to tell I don't do that. I still wait for the progression to happen, because I feel there is no data for that, and I would not want to waste. And sometimes some of a patient with the 6-cycle docetaxel have lived for years together and without any drugs. So that also benefit you lose if you start adding that thing. Rajesh, you wanted to say something?
No, sir. I wanted to ask some other question. How frequently we monitor testosterone level in metastatic setting, and how frequently you monitor?
Yeah, how frequently monitor in the second part
level?
Okay.
So
how frequently do you monitor the testosterone level? You asked me.
Yes. In metastatic setting and in adjuvant setting.
Okay, in adjuvant setting, the Akash, do you do it in adjuvant setting at all? The testosterone part of it?
No, sir.
Okay, so I'll answer the metastatic part. If what I do, I'll tell you, and if others differ, they can always tell me. I always look at and document the low level of testosterone at the month 3 or something. And if the patient is doing well and the response is good, I normally do not do it till I see a rise in the PSA. Once the rise in PSA happens or the symptoms happens, I will look at the testosterone level to see whether the rise in PSA is an actual rise because of the relapse or refractoriness, or there was something loss of a agent which you are giving. Taha, do you do it this way, or do you do testosterone like we do PSA every 3 to 4 months?
No, yes, sir. What you told is exactly the same thing.
So I think, Rajesh, that's the point which most of us do, that we do it once after we started 2 to 3 months to see the optimal suppression happened, and then once the PSA starts rising or symptoms are there, we then do the testosterone, see whether the PSA rise was due to that, or we can be assured that there was a hormone refractoriness to the progression of the disease. Now, okay, last thing which I wanted to brief. Any more questions? No. So radiotherapy to all sites, it was very clear, as Dr. Gaurav told, our expert, no. Low risk versus high risk, there was a little bit issues of the charted versus the stampede criteria. But what Dr. Gaurav told, I'll tell you, is he would look at the stampede more carefully. Anything more than 4, he would be very, very skeptical. And there is data to that effect which I showed, and that is the stampede data, that beyond 4, the benefit really goes away. Otherwise, for high risk, there is no role of a local radiotherapy to the prostate. Otherwise, we medical oncologists have to define low and high. And for the low risk, as per the criteria which you follow, please send the patient for radiotherapy to the prostate. ADT, yes. Intermittent, continuous, there are data for both. In guidelines, you find people, even there are symptoms, there are side effects, hot flushes, people do the intermittent, that's also fine. You do not compromise the survival. Oligometastatic, evolving field, more of PSMAs, more of choline scans will lead to more of oligometastatic disease, and that is where the role of radiation oncologists will come in. Surgeons, as of now, are still far away from the oligometastatic disease. Molecular selection, we discussed that, the BRCA, the ATM, the RAD, and there are multiple other genes which are there, and we need to look into this part also. With that, I thank all of you and thank the organizers especially for the invite, and I hope I added some value to this. Thank you.
Thank you so much, sir.
Thank you, sir. Thanks for the wonderful session.
So thank you so very much, Dr. Sahu. Brilliant as always, and you've always been a showstopper in all those meetings. So thank you so very much for this brilliant panel discussion, and of course thanks to all the panelists for to be a part of it. Now we switch the gears, and the next session is on renal cell carcinoma. We have a pleasure to invite Dr. Rajesh Patidar, the consultant medical oncologist at Chadra Hospital and Research Center Indore, and he's going to talk on the ideal sequencing evolving a strategy in RCC first line. So over to you, Dr. Rajesh, for your presentations. You have 20 minutes to deliver your talk. So over to you.
Slides are visible?
Sir, your slides are visible. We can hear you. You can move the slides.
Okay. Thank you, organizer, to giving me this opportunity to speak upon ideal sequencing and evolving strategy in renal cell carcinoma in a first-line setting. So we know that in renal cell carcinoma, there were different era, like what we have now, immunotherapy and TKI era. It started with cytokine era, then came tyrosine kinase inhibitor, then came immunotherapy, and now IO combo era, that immunotherapy and immunotherapy with immunotherapy in combinations. And when I started in DM, actually I entered in TKI era. That time it was sunitinib was the standard, then came pejopinib, and they compared pejogist and Pisces trial, and they found out that both were equal and pejopinib was better in terms of toxicity. Then cabozantinib and other TKI exitinib came in a second line, and then immunotherapy first came in a second line. Then immunotherapy came with combination of immunotherapy in first line, especially in high risk patients. And now immunotherapy plus TKI became the standard in even high risk and low risk patients of RCC. So if we see the evolution, the first drug which was approved was interleukin-2 inhibitor. It was back in 1992. Then came poor man's TKI, that was sorafenib, and it was first line approved in 2005. Then came sunitinib. It was approved in 2006. Then VEGF inhibitor, that is bevacizumab plus interferon alpha. It was approved in 2009. Then came everolimus and pejopinib. After that, exitinib was approved in 2012 in second line. Nivolumab was first approved in the second line in year 2015. Cabozantinib was approved in the first line high risk and second line patient in 2016. Then now we have various approval with immunotherapy with TKI like avelumab with exitinib, pembrolizumab with exitinib, nivolumab with cabozantinib, and IO combination, which is ipilimumab plus nivolumab, is approved in high risk renal cell carcinoma. So first we'll discuss the IO combination as a first line, that is IO plus IO, which is ipilimumab plus nivolumab. And IO plus TKI, there are 4 combinations are approved, that is pembrolizumab with exitinib, nivolumab with cabozantinib, pembrolizumab with lenvatinib, and avelumab with exitinib. So the evidence with IO combination came from CheckMate 214 study, and in this they compared with sunitinib in a treatment naive renal cell carcinoma patients. So in this study, in high risk patient, the median overall survival was 48.1 month versus 26.1 month, and the curves were well separated. But in favorable risk populations, the curves were overlapping and median OS was not reached. So IO combination has given more benefit in high risk patient compared with the favorable risk population. And if you see the PFS, in PFS also, it was 11.2 month versus 8.3 month in high risk population. And in favorable risk population, it was 12.4 month versus 28.9 month. So actually IO did worse in favorable risk population, and in high risk population, it did better with hazard ratio of 0.74. Then another immunotherapy approved was pembrolizumab, and it was approved in first line with exitinib, and evidence came from Keynote 426 trial. And in this trial, at 18 months, the overall survival was 81% versus 72%, and at 3 years, it was survival was 63% versus 54%. So with hazard ratio of 0.73, and if we see the progression-free survival at 3 years, it was 30% versus 15%. So it is almost, PFS was almost doubled at 3 years. Next immunotherapy, which is approved with TKI, is nivolumab, and it is approved with cabozantinib, and they also compared with sunitinib, and if we see the median PFS, it was 17 months versus 8.3 months with hazard ratio of 0.52, and if you see the median overall survival, it was not reached in immunotherapy arm compared to 29.5 months. The pembrolizumab is also approved with lenvatinib, and the evidence came from the CLEAR trial. They compared with sunitinib, and in this trial, the hazard ratio was 0.39 for survival, and they had 3 arms: pembrolizumab, lenvatinib versus sunitinib, and lenvatinib plus everolimus versus sunitinib. So the best arm was immunotherapy, that is pembrolizumab with lenvatinib. So if we see the median overall survival, the hazard ratio for immunotherapy was 0.66, which was statistically significant, and in combination with lenvatinib, in combination with everolimus, it has not shown benefit compared to sunitinib, and it has hazard ratio of 1.15, so it was slightly detrimental compared to sunitinib. So if we compare different combination of immunotherapy with TKI, median overall survival ranges from median overall survival hazard ratio ranges from 0.69 to 0.60. So almost all immunotherapy drug with TKI has given near around equal survival in terms of hazard ratio. And if we see the landmark oral survival at 12 months and 24 months, at 12 months, the median oral survival ranges from 83% to the 90% in immunotherapy arm. And at 24 month, median oral survival ranges from 71% to the 79% with all immunotherapy combinations. If we see the CR rate, it ranges from 11% to the 16%. And if we see the nephrectomy status, that is prior nephrectomy status, it was done in around 70 to 80% patients in all of these trials. So what is the pros with immunotherapy in combination with TKI? First benefit is it has shown consistent effect of benefit in all IMDC risk groups. It has shown significant tumor burden reduction reflection in overall response rate and long progression-free survival. It has manageable toxicity and overall survival and overall response rate advantage over TKI. It has overall survival and overall response rate advantage over TKI monotherapy. What are its cons are? Long-term durability of response yet to be demonstrated, and there are potential for acute and chronic TKI toxicities. But if you see immunotherapy combination, there is always the benefit is overall survival and overall response rate advantage were there in compared to TKI monotherapy. All those patients who responded, they responded very for a very long time, and there is a possibility, minimal possibility of treatment-free interval that is not there in IO plus TKI combination. But the disadvantage with this combination that this combination has not shown any benefit in the low risk patient and favorable risk patient. And second disadvantage was it has very low oral response rate, and it has very shorter PFS compared to the immunotherapy and TKI combination. So if you want response rate, if you want progression-free survival, then this is not a good combination. So what is our experience? Our experience means the experience from the India, and this was published from the Bangalore by Dr. Amit Rothan, and they have published with their experience with first-line immunotherapy with TKI in metastatic RCC. They have used pembrolizumab or nivolumab with exitinib or lenvatinib, and they have retrospectively observed this patient from 2019 to 2021. They treated 22 patients with IO plus TKI combination, and most of their patients were intermediate risk, that were 60%, and 27% of the patients were high risk in their study. What they observed? They observed oral response rate of 68%, and 60% of the patients had a partial response, and they found around 18% of the patients were having stable disease. So these responses were correlating with the responses what we have seen in IO plus TKI in a randomized trial. They have seen grade 3 and grade 4 immune-related adverse events in only 15% of the patient. One patient of there had colitis, one had pneumonitis, and one had encephalitis. TKI-related grade 3 and grade 4 adverse events were seen in 8 patients, and they were well managed with the dose reductions. So OS, oral survival at 1 year was 92%, and median overall survival was not reached. And this is what this is this survival is what we have seen in the phase 3 trial, and in real world also this immunotherapy plus TKI translated the same result as in phase 3 randomized trial. Now if we discuss this case, this is a 47-year female with right kidney renal cell carcinoma with multiple lung and brain metastasis, and this patient was started on immunotherapy combination with tyrosine kinase inhibitor. After 2 months, if you see this patient has responded very well. The lesion in the, if you see the MRI, the lesion in the brain has significantly reduced, and in the lung also, the number of the lesions has decreased, and the avidity, the avidity has also decreased significantly. So this is the first lesion, initial lesion in the brain, and after 2 months the lesion is almost disappeared, and in the chest also the number of lesions have almost disappeared with immunotherapy plus TKI combinations. So these are the various approved regimen as by NCCN. First, if you see the in favorable risk we have exitinib with pembrolizumab, cabozantinib with nivolumab, lenvatinib with pembrolizumab. All these 3 combination are category 1 recommendation. And in poor and intermediate risk, we have exitinib plus pembrolizumab, cabozantinib with nivolumab, IO combination like ipilimumab with nivolumab, lenvatinib plus pembrolizumab, and cabozantinib. Now, other in sequence, if we see the subsequent therapy for clear cell histology, various drugs have been approved, and this will be discussed in the next session by Dr. Asati. Thank you.
Thank you, sir. Thank you so much for your wonderful presentation. And next we move on to our next speaker, Dr. Vikas Astal, Associate Professor, Department of Medical Oncology, Sri Aurobindo Institute of Medical Sciences, Indore, and he's going to talk on ideal second line and sequencing in MRCC. Over to you, sir.
So good evening, everyone. Thank you, Dr. Rajesh, for covering the first line therapy. My slides are visible and I am audible.
Yes, sir. You need to make it slide show. Thank you.
Thank you. So I will start from the slide where Dr. Rajesh stopped. So what I have concluded from his talk that we have 2 combination with pembrolizumab, that is pembro plus lenvatinib and pembro plus exitinib, and with nivolumab we have nivolumab plus ipilimumab, that is IO, and another regimen with nivolumab is the cabozantinib. But the only thing we need to remember that the IO combination should not be using in the favorable subset because it is detrimental, and other 4 can be used depending on the choice. So this is about the first line setting, but we know that most of our patients will not be able to receive these immunotherapy in the first line setting, and most of our patient is going to receive either sunitinib or pazopanib, that is the TKI. So if once patient is progressed on either the sunitinib or the pazopanib, what options we have? So at present we have 5 options. One is the cabozantinib, the second one is the combination of lenvatinib plus everolimus, the third one is nivolumab, the fourth one is exitinib. So these 4 options are category 1 recommendation, and the last one is the everolimus. Whatever the regimen that are approved, the combination of immunotherapy or TKI or IO, they are also can be used in the second line setting, although the separate phase 3 trials in the second line setting may not be available, but we have a phase 2 data, and there is no reason why they should not be benefiting our patient in the second line setting, and we have a data to prove that. So let us start with the cabozantinib in the second line setting. The trial was the Meteor Trial. It was an open label phase 3 RCT which evaluated the efficacy of cabozantinib with everolimus in the patient of metastatic RCC who progressed on the TKI, that is sunitinib or pazopanib. There was around more than 600 patients who randomized between the cabozantinib and everolimus. The primary endpoint of this trial was the PFS. So this was the treatment schema, the study design. all the patients should have the clear cell histology at least as a component, and they should have progressed within 6 months of prior TKI. No limit of number of prior therapies, and PD-L1 checkpoint, they were also allowed. And the patient should have stable brain metastasis, and they will be randomized between the cabozantinib. The dose is 60 milligram once a day, and the dose of everolimus was 10 milligram once a day. And the patient was stratified based on KCC risk groups, either favorable, intermediate, or poor, and also based on prior number of therapies the patient has received. So this is the PFS curves, and we can see the median PFS in the patients who received the cabozantinib was 7.4 months as compared to the 3.8 months in the everolimus arm. So PFS looks better. And this is the overall survival. Again, we can see with the hazard ratio of 0.67, the median OS in the cabozantinib arm was 21.4 months as compared to the 16.5 months. So not only the PFS, the overall survival was also better in the cabozantinib arm. This is even a more mature data, and here also we can see the OS is better in the cabozantinib arm. And in this trial, about 5% of the patient received immunotherapy. As far as the response rate, it is 17% between 3%. We also have some retrospective data that when we use cabozantinib after immunotherapy, it is also benefiting the patients with median OS of 17.3 months. So this is about the cabozantinib. Now coming to the axitinib, which is again a TKI. It was studied in the ACCESS trial. It was a phase 3 trial. Again, the metastatic RCC patient with clear cell component, they were randomized between the axitinib 5 milligram BD against the sorafenib 400 milligram BD, with again the primary endpoint being PFS. And here we see that the PFS was better, 6.7 months in the axitinib arm, while in the patients who received the sorafenib, the median PFS was 4.7 months. But the OS, there was no difference in the OS between the two arms, which may be due to the subsequent active treatment which most of the patient has received, especially the immunotherapy or the combination of immunotherapy or TKI. As far as the safety part is concerned, the main toxicity with axitinib, hypertension and hypothyroidism, where as we know the toxicity of sorafenib are mainly the Hanford syndrome, rash, and alopecia. The third drug is the everolimus. The everolimus was studied in the RECORD-1 study. We know that is an mTOR inhibitor. And in this trial, the patients were randomized between everolimus versus placebo. So the control arm did not receive any active ingredient. And we can see the PFS as expected is better in the everolimus, 4.9 months. The placebo arm, the median PFS is 1.87 months. So there was a significant improvement with positive p-value, but the extent of benefit was just 3 months, which was small. And for OS, for the intensive treat population, so no statistical significant difference. And the reason can be the crossover was allowed in this trial. So after the 3 drugs, now the 4th drug is lenvatinib. Again, it is multi-kinase inhibitor. And every US FDA approved lenvatinib based on the phase 2 trial, the study 205, in which the combination of lenvatinib plus everolimus demonstrated a significant increase in PFS, response rate, and also the OS as compared to the everolimus alone. This is the treatment schema. There was 3 arms in this trial: the everolimus 10 milligram, lenvatinib 24 milligram, and the combination arm, the dose of lenvatinib was 18 milligram. Plus the dose of everolimus was 5 milligram. And the measure, again, the primary endpoint was the median progression-free survival. And again, we can see that the PFS was better in the patients who received the combination of lenvatinib and everolimus. And again, we can see that the response rate with this combination was high, at around 43%. And we will see in subsequent slide that this is the maximum response rate we get with any of the therapy. Coming to the nivolumab, the trial was just published when I joined my first year DM course. And in this trial, the patient, metastatic RCC patients who has received at least one prior lines of therapy, they was randomized into the nivolumab in the dose of 3 mg per kg every 2 weeks versus the everolimus, and the primary endpoint was here the overall survival. And we can see that the graph started separating almost in the first couple of months only, and the median overall survival in the nivolumab arm was 25 months as compared to 19.6 months in the everolimus arm. And there was OS benefit, but there was no PFS benefit in this trial, and the response rate also favors the nivolumab arm, and the expression of PD-L1 did not have any impact on OS or overall response rate. This is slightly more mature data, the 5-year data. We can see the PFS and the p-value might not be significant, but when we see the overall survival, I think and beyond doubt that nivolumab is much better than the everolimus. And we can see the tail of the curve that the patients who respond, they respond for a longer duration of time. So this is the tabulation of all the trials that we discussed for everolimus, exitinib, cabozantinib, nivolumab, and the combination of lenvatinib plus everolimus. The response rate was the highest for the combination of lenvatinib plus everolimus, and the lowest was for everolimus alone. And it will not be good to compare the one trial with the other, but again, if we try to see that the survival was maximum with either nivolumab alone and also the combination of lenvatinib plus everolimus. And but the only problem when we use everolimus, there is a toxicity that we need to keep in mind. As far as sequencing is concerned, I think we are still learning, and with more data coming in, we will know how to use the drug one after the other. But one thing which is very clear that in the first line setting, the combination of immunotherapy with either TKI or IO, especially in the intermediate or high risk patient, is the way to go if my patient can afford. So that's all from my side. Thank you so much.
Thank you, sir. Thank you so much. And next we move to the next session, hematology malignancies. And the session is sponsored by our academic partner, Pfizer. And for this, I would like to invite Dr. Datta, who is consultant hematologist, Bansal Hospital, Bhopal. And he's going to speak on changing the treatment landscape of relapsed or refractory B-cell adult ALL. Over to you, sir.
I'm sorry, going to join in a couple of minutes.
Okay, fine. So let him come, then we'll introduce. Or should we move on to the next speaker?
No, sir. No, ma'am. Dr. Ravi has also not joined.
Fine, so let's wait. Aram, let me know once doctor joins, right?
Yes, yes.
Good evening, sir.
Sir.
Yeah. Good evening, Datta sir. So I would like you to invite for today's session, sponsored by Pfizer, our academic partner, on hematology malignancies. And doctor is going to speak on changing the treatment landscape of relapsed or refractory B-cell adult ALL. Over to you, sir.
Can I share my screen?
Yes, sir.
Is it visible?
Yes, it's visible. Just speak it in a slideshow mode, sir. Yeah, you can go ahead.
Good evening, all. At the outset, I would like to thank Dr. Akash Tiwari for inviting me to this beautiful session. Today, my topic is changing treatment landscape of relapsed refractory ALL. Now, I will discuss mainly about B-cell ALL. As you all know that the pediatric ALL have very good prognosis with overall response rate and overall survival more than 90% in US and European study. And even in India, we have overall survival at more than 70% in pediatric age group. But when we come to adult population, the prognosis is not so good. And even more than 45 years of age, the overall survival rate is less than 20%. This is a SAR data of around 2 decades, which show decreased survival when the age increases. Nowadays, we have made several changes in our ALL adult population. We are using pediatric-based therapy for the adult patient. We are decreasing the AL asparaginase dose, and with advent of many of such armamentarium, we have increased the overall survival of adult ALL population in upfront. But still the overall survival is 30 to 50%, not more than that. And when that ALL adult population relapses, the prognosis is dismal. You can see in this MRC UKLL trial, the 5-year survival is only 7% in the first relapse. And when age is more than 35%, 35 years, the overall survival is only 4%. So it's a very dismal prognosis when adult ALL relapse. Now the survival of adult ALL relapse situation depend on several factors. Most importantly, the response of the therapy which are using in salvage. If the patient goes into CR after salvage therapy, then the response rate is bit better, like around 40%. But if CR is not achieved, then the prognosis is dismal, it's less than 10%. And in CR, patient must have undergone hematopoietic stem cell transplant, and only then overall survival approach 30 or 40%. Without transplant, the prognosis is very bad for adult ALL in a relapse condition. Here are the several trials. We have data from French group, Spanish group, and German group. They used conventional chemotherapy. These are the all old trials, and this trial achieves CR rate around 40% in all the trials. It's like 42 to 44%. It's around 40%. It is in first relapse. When it's second relapse, the CR rates is around 20%. These are the therapy which we use nowadays for consolidation. These are conventional chemotherapy. These are actually used by German group. They use consolidation 1 for most of their patients. It consists of dexamethasone, vindesin, high dose methotrexate, etoposide, high dose Ara-C. Commonly, we also use FLAG-IDA or CLAG-E regimen for salvage of relapsed ALL patient. Now, with this conventional therapy, around 40% patient goes into CR, and if they underwent transplant, overall survivals come to around 23%. Without transplant, if patient only takes chemotherapy, then the overall survival is only 4%. So it's very important for adult ALL relapse patient to undergo transplant, and even then around only 1/4 of those patients go for long-term survival. And if the patient achieves CR, in this situation, MRD negativity is very important. This is a large EBMT data. This is a retrospective data of around 1,800 people. Those 1,800 patients, 900 was MRD positive and another half was MRD negative. And if those MRD negative patients went into TBI-based transplant, then the overall survival and leukemia-free survival is around 60%. And if MRD is not achieved before transplant, the prognosis is poor, is less than 40%. Relapse refractory ALL survival also depends upon the age of the patient. As I already said, younger the patient, prognosis is better. More than 45-year prognosis is dismal. And the patient, if relapse very early, especially within a year, then also the prognosis is dismal. Even with transplant, they fare very poorly. So we have much room for improvement, because even with CR, even with doing transplant, around 75% patient relapse and long-term survival is achieved only less than 25% patient. This high-dose chemotherapy, which we use in salvage therapy, those are very toxic. There is much treatment-related mortality. Now, ALL have very unique feature is this blast cell have very high density of antigen, and these blasts have antigen which doesn't shared by the normal cell population of our body. So ALL become a very good target for immunotherapy. These are the important target which we can use in ALL salvage therapy. Like CD20, we are using for many years rituximab in upfront therapy of ALL. Now CD19 and CD20, these are new target which you can use in your salvage therapy. These are now not recommended with upfront therapy. Blinatumomab, which is a bispecific T-cell engager. This also targets CD19, and tisagenlecleucel, which is a CAR T therapy, which also targets CD19 of ALL blast. CD20 is targeted by I Anatosumab ozogamicin. So these are the new drugs we have in our armamentarium for treating relapsed refractory adult ALL patients. First, I will discuss about blinatumomab. Now, this ALL blast have unique feature. Like any cancer cell, they are very elusive. They can evade our immune system. Our body's T cell cannot target this ALL cell. So we have this bispecific T cell engager. It's bind to CD3 of T cell and CD19 of B cell blast. So these T cells are able to lyse those cancer cells. This is Tower trial, which compared blinatumomab with standard of chemotherapy in pH negative B cell ALL adult patient. They may be first relapse or second relapse. And this phase 3 trial showed median overall survival of 7.7 months in blinatumomab group and only 4 months in standard of care group. In standard of care group, they use FLAG, HiDAC, high-dose methotrexate, and clofazimine based regimen. So this survival graph is not very impressive. So even with use of blinatumomab, only blinatumomab, the survival is not much. But this survival benefit is seen across the subgroup, across the age group, or blast cell percentage, or number of salvage treatment given previously. With blinatumomab, the response rate is around 40% compared with conventional chemotherapy, which produce response rate of around 25%. Now, blinatumomab treated patient who went to CR, around 76% patient are MRD negativity. So most of the patient who went to CR, they are MRD negative. Most important adverse effects which are seen with blinatumomab are neurological event and cytokine release syndrome. Blinatumomab given as a continuous infusion for 4 weeks. This is a long-term data of blinatumomab. It's very interesting to see that if the blinatumomab treated patient underwent stem cell transplant, they produce overall survival, long-term survival approaching around 40%. So this data is very interesting. Previous data we have seen that the overall survival after conditioning, chemotherapy and transplant is around 25%. But this newer therapy, newer targeted therapy, there is much more increased survival. Though we should not compare cross trial, like we shouldn't compare one trial with another. But as a result, we can see in this long-term data that overall survival is increased with use of blinatumomab. Now, the second drug in our armamentarium is I Anatosumab ozogamicin. This is an antibody drug conjugate. Antibody is CD20, anti-CD20, and drug is calciamycin. So this antibody drug conjugate bind to this ALL cell, and this inotuzumab and calciamycin get internalized, and then calciamycin released from this antibody, and they cause double strand break in the cell. Ultimately, this cancer cell apoptosis. Innovate trial is a phase 3 trial which compared inotuzumab with standard of care. Inotuzumab is a as compared to blinatumomab, which is a continuous infusion. Inotuzumab is a 1 hour infusion that given in day 1, day 8, and day 15. The dose in day 1 is 0.8 milligram per meter square, and day 8 and day 15 is 0.5 milligram meter square. Usually we give 1 or 2 cycles, then go for transplant. If the patient in non-transplant eligible, then up to 6 cycles can be given. In this trial, standard of care chemotherapy was FLAG, RSC plus mitoxantrone or HIDAC. These are the conventional chemotherapy which are given in other group. So this study produced an excellent result. They produce around 80% of CR rate compared with only 30% with conventional chemotherapy. So inotuzumab produced remarkable result with this relapsed patient. And this result was seen across the subgroup, whatever the bone marrow blast, whatever the number of previous therapy. Even patient who underwent previous stem cell transplant, around 76% patient underwent complete remission with use of inotuzumab. And those patients who underwent in complete remission, around 78% patients were MRD negative. So with inotuzumab and blinatumomab, both are produced around 80% of MRD negativity. And with use of inotuzumab, around 50% patient can go for stem cell transplant. As they are going to CR, they can get a transplant after inotuzumab. So with use of inotuzumab, the CR rate, the MRD negativity rate, and the transplant rate, everything improves. This is a long-term data of Innovate trial which produced 2-year survival of 23% compared with 10% with standard of care chemotherapy. And when this inotuzumab treated patient underwent stem cell transplant, the long-term survival, 2-year survival approaching 40%. So like blinatumomab with inotuzumab and stem cell transplant, the overall survival, long-term survival reached up to 40%. So it's a great achievement with use of inotuzumab. The major important adverse effect with inotuzumab is veno-occlusive disease. Actually, this drug causes damage to the hepatic sinusoidal epithelium, and the patient usually present with jaundice, weight gain, pedal edema, and gradually it may progress to pulmonary infiltrate renal failure and multi-organ dysfunction. Actually, a patient who were undergoing transplant, they have more veno-occlusive disease, and if they have baseline hepatic damage and dual alkylator conditioning, then the veno-occlusive disease rate is much more than the other patient. Now, in some recent trial, we have seen this veno-occlusive disease is very low with use of inotuzumab. This is a US trial which showed that with use of inotuzumab, not a single patient have veno-occlusive disease. In this trial, they use conditioning therapy, mostly fludarabine menferin, otherwise flumel TBI, flu-bu, and etoposide TBI. With all this conditioning regimen, they haven't experienced a single case of VOD. So it's a very encouraging data because VOD is a very fatal condition, and defibrotide, which is used in case of VOD, is a very costly medication not available in India. When we bring it from European country, the cost is very high. So third, in our armamentarium is CAR T-cell therapy. Now, as we have already discussed, that this cancer cell, they do not express MCH molecule, so they cannot be killed by body's own T cell. So we are engineering cells so they can kill this cancer cell. We are transducing this patient's T cell with lentivirus or retrovirus, and so that this T cell can produce some receptor which can attack the patient and cancer cell. So these are the second and third generation CAR T cell. They have anti-CD19 target, anti-CD19 receptor that bind to the blast cell CD19, and they have co-stimulatory molecule like CD2841BB. This co-stimulatory molecule actually help this CAR T cell to expand rapidly inside the body, and with help of this co-stimulatory molecule, this CAR T cell survive for prolonged time in patient body, so they become more effective than the first generation CAR T cell. There are several trials for CAR T cell. This ZUMA-3 and MSKCC trial taken the adult patient, and this trial show the median survival rate around 1 year, even with transplant and non-transplant patient. The survival rate is similar for this trial. This is the ZUMA-3 trial, which use conditioning chemotherapy, fludarabine and cyclophosphamide, and they use several different doses of CAR T cell. These are 2 into 10 to the power 6, 2.5 into 10 to the power 6, and it has been shown that 1 into 10 to the power 6 CAR T cell per kg patient body is the optimum, and they produce around 16 months of median overall survival. Now, these were the pH negative B cell. If the patient is pH positive, like this patient is a 20-year-old patient, pH positive ALL post-transplant relapse. Now, with conventional chemotherapy, these cases cannot be managed because they don't respond to conventional chemotherapy. So what can we use for this? Blinatumomab, I Anatosumab, or maybe some different TKI like ponatinib. Alcantara trial showed that pH positive B cell ALL, we can use blinatumomab successfully. The dose is same like pH negative B cell ALL in first week 9 microgram per day, and second to fourth week 28 microgram per day. 5 and 6 week we don't give any therapy. If the blast is less than 5%, they can get maintenance therapy for another 12 cycles. In Alcantara trial, the overall survival, median overall survival is around 23 months. And in Innovate trial, they also included pH positive patient, and they had around 78% remission rate with this pH positive ALL. There's a very good response rate when come to pH positive ALL relapse after transplant, after TKI and high dose therapy. So with this, I would conclude my talk, because these are about T cell. We won't discuss T cell today. Thank you.
Thank you, sir. Thank you so much for the wonderful presentation. Next, we move on to today's last speaker, Dr. Ravi Jaiswal, who is consultant medical oncologist, Ramakrishna Care Hospital, Raipur, and he's going to talk on changing landscape of myeloma management with the advent of MAB in Indian context. Over to you, sir.
Thank you so much, Dr. Akash Tiwari and Johnson & Johnson for having me here. So this is an sponsored session. Is my screen visible to all of you?
Yes, sir.
Okay. So After a lot of interesting presentations today, we are going to talk about changing landscape of myeloma management with the advent of monoclonal antibodies. We are going to talk about what are these monoclonal antibodies that are used in multiple myeloma. How should we manage a new case with multiple myeloma? What should be our approach towards a relapse refractory multiple myeloma? What is the supportive care and what is the precision medicine that is coming in multiple myeloma? So if we look at the various monoclonal antibodies targeting multiple myeloma, we are aware of daratumumab, that is a CD38 monoclonal antibody. But apart from that, we have elotuzumab, which targets the SLAMF7. We have isatuximab, which targets another epitope of CD38. And we have a bispecific antibodies, which target the CD38 plus CD3. Coming to daratumumab, it is a drug which has been studied in a lot of phase 3 trials in different settings. The mechanism of action of this drug is as such. You can see there is a myeloma cell in the center with a lot of antigens, and this monoclonal antibody, it acts directly on the tumor by a CDC, that is a complement dependent cytotoxicity, or another mechanism of action like antibody dependent cellular cytotoxicity, phagocytosis, apoptosis. Apart from that, it also has an immunomodulatory action wherein it modulates the tumor microenvironment, suppresses the Treg cells, and kills the myeloma cell. A lot of phase 3 studies in different settings of myeloma, right from your relapse refractory setting to your new case, which is a non-transplant dependent or a transplant eligible case. It has been studied across various trials. Coming to 2017, back then when I was also a resident in oncology, the frontline treatment options for symptomatic patients with multiple myeloma who are transplant eligible was either a doublet or a triplet combination. If the performance status was good, we usually consider a triplet combination of a proteasome inhibitor, immunomodulator, and a steroid, like your VRD, VTD, or a VCD regimen. And all these patients, after achieving a good response, were subjected to a stem cell transplant, and they were put on a lenalidomide maintenance. But now in 2021 guidelines, which come from the ESMO, they recommend the use of a monoclonal antibody even in the induction. So this is slightly different from your NCCN guidelines. Remember, the NCCN guidelines still don't talk about using daratumumab upfront in transplant eligible patients, but the ESMO guidelines have included daratumumab even for transplant eligible patients. So where does this evidence of daratumumab comes from? So let's first talk about this Cassiopeia study. This study included a regimen which is dara plus bortezomib plus thalidomide and dexamethasone in patients who are transplant eligible. And the focus of this study was to look about MRD. So MRD has come up a big way now in multiple myeloma, and the aim of this study was to present the MRD results from Cassiopeia to demonstrate the impact of DARA maintenance on MRD negativity. The study had two arms. One had the 4-drug combination with a DARA and other was a VTD regimen, wherein your DARA was used at 16 mg per kg. It was weekly for the first 2 cycles and subsequently it was twice a week. Then they did MRD at post-induction. The second MRD was done post-consolidation, and the third MRD was assessed after maintenance. And the study showed us that whenever this regimen containing DARA was used, more patients had a CR and a MRD negative status. And this MRD negative status and CR status was even higher when it was used during maintenance. So across all subgroups that have been studied in this study, it was uniformly seen that wherever we used a regimen which had a daratumumab, it translated into more CR and MRD negativity status. So compared to observation, using a daratumumab as a maintenance strategy was shown in this study to have superior outcomes across all subgroups. And the conclusion of this study was that the MRD negativity was higher in patients post-induction, post-maintenance, and at this point in time, remember, we don't know actually whether this MRD negative status translates into overall survival or not. And there are studies ongoing to answer this question. Now let's move on from the MRD negative study to another study, which is a MIA study, which talks about use of this drug daratumumab in patients who have impaired renal function. We see a lot of patients with impaired renal function in our day-to-day practice. And this is a beautiful study which talks about two things. One is whether you should use Dara plus RD versus RD, or you should use a less dose of lenalidomide in these patients. And the outcomes, the endpoints of this study were PFS, response rates, CR rates. And across this study, it was found that patients who received a combination of Dara-Len-Dex had better PFS and OS compared to patients who received only Len-Dex. And if there were patients who had an impaired renal function, there the study allowed a lesser dose of lenalidomide, that was approximately 10 to 15 milligram. So the study tells us that at a follow-up of 5 years, the PFS and OS was beneficial in the group which had received Dara, and if patients had a renal impairment, it was better to use a lesser dose of lenalidomide. Now, let's move in from a 3-drug combination to a 4-drug combination for a patients who are transplant eligible. So this is the Griffin study, which used Dara, Len, bortezomib, and dexamethasone for patients who are transplant eligible. It had a standard of care, that is RVD. The dose was same for Dara, 16 mg per kg. It was given weekly and then subsequently twice a week. Patients were allowed to undergo a stem cell transplant, followed by consolidation and dual maintenance with Dara-Len versus Len alone. And the beautiful study, treatment arms exactly balanced. And you can see in this slide that the Dara RVD arm had more response rates, that more patients had CR compared to your RVD arm, that is 60% versus 47%. That means the response rates and the depth of response was greater when an additional monoclonal antibody was used upfront in these patients. And the MRD negativity was also high. Across all subgroups, it was found that it benefited all the patients irrespective where they fit into, whether they had a high risk or a standard risk, whether it was ISS 1, 2, 3, whether less than 65, more than 65. So everybody had a benefit with daratumumab. It had a better PFS compared to the combination which has used only RVD. The common toxicities we are aware of when we are using daratumumab are infections and infusion reactions. Remember, infection rates are higher. It is said that if you use daratumumab, approximately 50% of patients, they get into infections, and 20 to 30% of patients, they have infusion reaction. And that is the only reason when you're using this drug in the first cycle, your duration is for 7 hours. And subsequently, if the patient tolerates well, then you can cut down on the duration to 3 to 4 hours. So that was the same toxicities that was seen in this trial as well. Approximately 40-50% patient had infections, particularly the upper respiratory tract infections were common. The conclusion of this study was that when you use a 4-drug combination followed by dual maintenance, it improved your responses and the depth of your responses. Your PFS is higher. However, we still don't have an overall survival data. Though it looks promising, we don't have an overall survival data to say that it should be a standard of care. And now let us come to another part of the story, that is what for those patients who are not transplant eligible. So the 2017 guidelines, they talked about a VRD or an RD regimen, but as you come to the 2021 and 2022 guidelines, they all talk about using this monoclonal antibody daratumumab upfront, particularly for patients who are not eligible for stem cell transplant. And where does this evidence come from? This evidence comes from this study, which is known as the L-Sion. So this study used Dara plus Boti, Melphalan and Predni, which is known as the VMP regimen. So this VMP was compared with Dara VMP, followed by a Dara for at least 4 cycles until there was a progressive disease. And at a median follow-up of 40 months, it was found that the patients who had the opportunity to get the Dara had a remarkable improvement in PFS. And it was seen that more patients achieved deeper response with DVMP, which led to better PFS, time to next therapy, and overall survival. So more patients had a VGPR rate and a CR rate when they were put on a Dara. They had more MRD negativity, and this was a sustained MRD negativity, which was seen even at 40 months of follow-up. So the survival outcomes at 42 months also favored the combination by a hazard ratio of 0.6. That means a 40% reduction in risk of deaths in patients who received a Dara combination. A surprising thing here was that patients in this study, even though they had received Dara with VMP, they had lesser rates of treatment discontinuation. That was a little surprising to me, but that is a clinical trial, and they have the trials are done in a proper setting. So maybe they had this opportunity to convince the patient and put them on right treatment. But in your day-to-day practice, it is really difficult to hold on these patients without treatment discontinuation for a longer duration. The conclusion of this study was that at a median follow-up of 40 months, when you use this combination, it led to better MRD negativity. There was PFS and OS benefit, and this led to inclusion of this Dara combination as a first-line option for patients who are transplant ineligible. Now, this slide that you see on the screen reminds me of the ovarian cancer slide that also talks about the subsequent therapies in ovarian cancer, that your remissions or shorter lived when you have a relapse, and the similar is the story with multiple myeloma. So whenever we have a patient of multiple myeloma at relapse, we consider a host of factors. How is the cytogenetics? How is the LDH? What are the host factors? What is his performance status, age friability, and the most important, what treatment the patient has received previously, whether the patient had received a lenalidomide, a bortezomib, whether he had undergone a transplant, and how sensitive was he to these treatments. And the most important treatment decision that we do is, if the patient is lens sensitive, we give them an opportunity to get a regimen that contains a lenalidomide. If the patient is refractory, we may prefer a pomalidomide or a bortezomib and not use the same drug. So the aim of subsequent treatment of myeloma is to give them another group of drug or another drug from the same category in order to have a better response. And this is what all these guidelines talk about. And there's always a monoclonal antibody that is given in combination wherever there is an opportunity to use these drugs, particularly for patients who are dual refractory to your lenalidomide, they're refractory to your bortezomib. That is the situation where this monoclonal antibody has a huge role to play, and that has been seen across all these studies. So now let us talk about other drugs that have come up in a big way in relapsed refractory multiple myeloma. One such drug is Panaminostat, which is a pan-HDAC inhibitor, which has been FDA approved for these patients who have failed bortezomib as well as lenalidomide. The another drug is Selenoxer, which is an expoprotein 1 inhibitor, and it is used for patients who are triple class refractory, that is a proteasome inhibitor, and IMiD and DARA as well. Apart from that, you have melphalan, you have a BITE T cells, and I also had the opportunity to see a couple of patients who were on clinical trials on CAR T cell therapy when I was at a short fellowship in United States. And CAR T cell therapy, let me tell you, is coming up in a big way for patients with multiple myeloma who have failed 2 or 3 lines of therapy, particularly with monoclonal antibody as well. The role of supportive care in multiple myeloma is very important and has to be remembered, because this is what gives you a better PFS, better quality of life. These patients require a bisphosphonate to manage their hypercalcemia. Whenever required, there is radiotherapy, vertebroplasty to help the bone disease. They have a lot of these drugs have a neuropathic pain wherein you need to kind of use a lot of antidepressants and anticonvulsants. In renal failure, we need to be very, very careful to use our drugs. Patients may require dialysis at a particular time if they are into renal failure. Anemia may not be always related to the disease or the drug that you use. They could be a contributory factor like the iron, folate, B12, which has to be corrected. Always remember to put them on aspirin and LMWH prophylaxis. Very important to vaccinate these patients. Vaccination is very important, particularly in our settings, and close monitoring of peripheral neuropathy. There's another important concept. This is the MMRF MyDrug protocol, where they are sequencing these patients who are on multiple myeloma. So they have this NGS, which has 1500 sequencing platform. They're looking up for this genomic profiling as to what all these mutations these patients can harbor. And this is an ongoing study at the moment. So to quickly summarize that, we've talked about a lot of monoclonal antibodies. They have come up in a big way in multiple myeloma. They are very, very important. They are coming up in your treatment algorithm, right in your first line, even in transplant eligible, transplant ineligible, relapsed refractory setting. There's not only daratumumab, but other drugs as well, which have come up into the picture. So this has led to a rapid shift in the therapeutic landscape and a lot of treatment options, including immunotherapy. Precision medicine is coming up in a big way. So it is very important to be aware of all these treatment regimens, a holistic approach, and a good teamwork and a proper sequencing of therapy is all that we need to achieve a better survival for our patients. Thank you so much for your kind attention.
Thank you so much. And I would request Dr. Akash Tiwari for the concluding remarks. Over to you.
So we've had 2 days of extensive academic discussions, and I must tell you, it was a feast for me. I hope everybody else enjoyed. I'd like to take this opportunity to thank Horizon as well as Tarunji's team for such a wonderful management of things. I'll also like to thank our scientific partners, Pfizer, Roche, AstraZeneca, Novartis, Janssen, and MedGenome for helping us bring this to everyone with such grace. Thank you, everyone. Thank you very much.
Bye-bye.
Thank you. Thank you, sir. Thank you, everyone, for joining. Good night, everyone.